Get ready to dive into some groundbreaking medical research. Rusfertide, a game-changer in the treatment of polycythemia vera, PV, has shown remarkable results and is making waves in the medical community. This innovative therapy is revolutionizing the way we approach PV, and the latest findings are nothing short of impressive. The power of Rusfertide, controlling hematocrit and reducing phlebotomy needs. Rusfertide, a hepcidin mimetic, has demonstrated its efficacy in maintaining hematocrit levels below 45% and significantly reducing the need for phlebotomy procedures in PV patients. The Phase 3 Verify study, presented at the 2025 ASH annual meeting, revealed that Rusfertide provided consistent and durable control of hematocrit levels, offering a promising new treatment option. Rapid and sustained response, a game-changer for PV patients. For patients who switched from placebo to Rusfertide, the results were astonishing. Within just 4 weeks, their hematocrit levels dropped rapidly and remained stable, indicating a swift and effective response to the treatment. This finding is particularly exciting as it offers a quicker and more sustainable solution compared to traditional methods. Consistency is key, similar outcomes for all patients. Regardless of whether patients received Rusfertide or a placebo in the initial phase of the study, their hematocrit control levels were comparable by week 52. This consistency in outcomes highlights the reliability and effectiveness of Rusfertide, providing a consistent treatment approach for all PV patients. Response rates soar, a success story. The response rates for patients continuing Rusfertide from the first part of the study to the second were impressive, with an increase from 76.9% to 84.1%. For those who switched from placebo to Rusfertide, the response rate skyrocketed from 32.9% to a remarkable 77.9%. These numbers speak for themselves, showcasing the potential of Rusfertide to transform PV treatment. Lead investigators take Rusfertide's impact. Andrew Kuykendall, MD, the lead investigator from Moffitt Cancer Center, emphasized the significance of Rusfertide's performance. He stated, Rusfertide met all primary and secondary endpoints in the Verify study, providing sustained control of hematocrit levels and phlebotomy ineligibility. After 52 weeks of treatment, Rusfertide was well tolerated with a consistent safety profile. Verify data update, Rusfertide's performance in PV. Rusfertide maintained hematocrit control below 45% and high phlebotomy ineligibility rates for 52 weeks in PV patients. Patients switching from placebo experienced rapid and sustained hematocrit reduction, normalizing iron parameters without worsening systemic iron deficiency. The treatment was well tolerated, with mostly mild to moderate adverse events, supporting long-term evaluation and regulatory submission. Unraveling the Verify study design. The Phase 3 Verify study was divided into several parts. In Part 1A, patients were randomly assigned to receive either the current standard of care plus Rusfertide or a placebo for 32 weeks. After this initial period, patients in the placebo group crossed over to receive Rusfertide along with the standard of care. Part 1B, an open-label phase, continued until week 52, assessing the durability of response. Standard of care included phlebotomy with or without cytoreductive therapy. Subsequent parts of the study are ongoing to evaluate long-term safety. Baseline characteristics, a balanced approach. Kuykendall noted that baseline characteristics were well balanced between groups in Part 1A of the study. In Part 1B, the median age was 57 years, with most patients being male, 72.6%. Nearly half of the patients had high-risk PV, 44.9%, defined as having a prior thromboembolic event and/or being aged 60 or older. The median age at PV diagnosis was 51 years, and the median PV duration was 2.9 years. Treatment approaches, a diverse range. For Part 1B of the study, nearly half of the patients were not on cytoreductive therapy, 44.9%, consistent with Part 1A. Among those on therapy, hydroxyurea was the most common, 38.3%, followed by interferons, 13.9%. A small subset of patients were on ruxolitinib, 2.6%, Jakafi. Part 1A results, Rusfertide's superiority. In Part 1A, Rusfertide outperformed placebo across all key endpoints. Response rates more than doubled with Rusfertide, 76.9%, compared to placebo, 32.9%, p less than 0.0001. Additionally, 62.6% of patients on Rusfertide had a hematocrit lower than 45%, compared to only 14.4% for placebo, p less than 0.0001. The mean number of phlebotomies required was significantly lower with Rusfertide, n equals 0.5, compared to placebo, n equals 1.8, p less than 0.0001. Patient-reported outcomes also favored Rusfertide. The PROMIS Fatigue SF8 score showed a decline of 1.78 for Rusfertide, suggesting less fatigue, minus 1.95 delta, p equals 0.0268, compared to a 0.17 increase with placebo. Similarly, the Myelofibrosis Symptom Assessment Form version 4.0 total symptom score 7 items showed an improvement of 2.40 for Rusfertide, minus 1.87 delta, p equals 0.0239, compared to a 0.54 drop with placebo. New findings from Part 1B, Rusfertide's long-term impact. The median time to phlebotomy was not reached in the Rusfertide arm for Part 1A, compared to 16 weeks in the placebo group. In Part 1B, the median time to phlebotomy was not estimable in either arm. Kuykendall explained, once patients switched from placebo to Rusfertide, the time to first phlebotomy looked similar in both groups. Ferritin levels normalized over time for patients receiving Rusfertide, with continued improvement throughout the study. There was no change with placebo in Part 1A, but a consistent climb in ferritin levels once patients crossed over to Rusfertide. Serum iron levels showed a small increase in both groups, from -6 mol at baseline to -10 mol. Transferrin levels decreased with Rusfertide, while transferrin saturation increased. These shifts were more pronounced in patients who switched from placebo to Rusfertide. Kuykendall added, Rusfertide lowered hematocrit levels without exacerbating systemic iron deficiency. There was a modest improvement in mean corpuscular volume levels with Rusfertide. Leukocyte counts remained stable in both arms, with a slight increase, and platelet counts improved with Rusfertide. Safety profile, Rusfertide's tolerability. At the data cutoff, 86.7% of patients continued to receive open-label Rusfertide, with discontinuations being uncommon, according to Kuykendall. In Part 1A, only 7.5% of patients discontinued Rusfertide due to adverse events, AES, n equals 8, or study withdrawal, n equals 3. This compares to a discontinuation rate of 4.1% in the placebo group for AES, n equals 5, and disease progression, n equals 1. In Part 1B, the discontinuation rate was 2.6%, with 3 patients discontinuing due to AES, 2 due to lack of efficacy, 1 for other reasons, and 1 for study withdrawal. In Part 1A, there were fewer secondary cancer events in the Rusfertide group compared to placebo, 3 vs 8, respectively. In Part 1B, those who switched from placebo had 2 cancer events, compared to 4 events in the arm that received Rusfertide in both Parts 1A and 1B. Most AES were grade 1 or 2 in severity. In Part 1A, at least 1 treatment-emergent adverse event, TEAE, occurred in 86.3% of the placebo group and 90.3% of the Rusfertide group. In Part 1B, TEAE rates were similar between groups at approximately 75%. The most common grade 3 TEAEs were anemia, asthenia, and hypertension, occurring in 3 patients each. Serious AES were experienced by 3.4% of patients in Part 1A and 2.6% in Part 1B. In Part 1A, Injection site reaction